So everyone's ready to learn wonderful things.
Yes, sir.
All right, so we have moved on past patient assessment airway management. You are now one course down, 19 more to go. I think it's less than that, but it seems like that much left to go. We are now going to get into some really meaty stuff. We kind of started some of the meaty stuff with the last few lectures on hypovolemia and whatever those other things were. This one's got a lot of really nasty, just beat down, mean, you gotta learn rote memory stuff. And the thing you have to realize is that this stuff, even though it looks boring right now, how our inflammatory and immune response work is gonna be boring, it's gonna be detail oriented. I'll guarantee it's even boring for me. Shouldn't have told you that, but it is. But I'll tell you what is so important about it is this affects almost everything else we do in this program. This is probably one of the best foundational lectures that we have. If you don't understand this, you'll never understand trauma, you won't understand wound healing, you won't understand most of the healing processes in other diseases. You'll definitely never understand anaphylaxis. It's all based on inflammatory immune response. So it really has a lot of important stuff in it. Now I say that because there were a lot of people in here who didn't do so well on the last final. And keep in mind, that was the easy class of this semester. So those of you who looked at that and said, ooh man, I pulled that one out, you're gonna have to step up. It's time to separate the men from the boys, or the adults from the children, however you want to put it. We're about to get into a little bit heavier stuff than we've had with the patient assessment and airway management stuff. So this will be tougher. And it doesn't really get much easier, because next semester we're going to look at cardiology, which is learning the language of the heart, that stuff. And it just kind of keeps going. So it's time to start kind of finding out what your pace is for studying. If you need help, get with us and we'll help you out. We're not here just to talk to you from 6 to 10. If you have questions beforehand or afterwards, we're here to help. I know I always like to tell people I have an open door policy, but for some reason someone keeps closing my door. I hate that. Can't stand it, to be quite honest. But just come in if you think I'm in there and we'll work on whatever issues you have. All right, so first of all, let's look at the issues of the inflammatory immune response of what we are going to deal with for most of the evening tonight. When we look at inflammatory immune issues, these are part of our self-defense. How does our body defend itself from invading organisms like, this Ebola thing that apparently everyone's going to die from? And I just laugh because it's just the most overhyped thing there is. When we look at how our body defends itself, the first thing we have is something called anatomical barriers. What do you suppose it is?
Skin.
It's skin. If your skin is intact, if your eyes are closed tight, your mouth's closed shut, and you do this, you'll probably never get a disease. It won't come through. Our skin is a very good barrier. So that helps a lot. The problem is what happens when we get past these anatomical barriers. Well, then we have an inflammatory response and an immune response that will start to play a very major role in how we avoid disease and how we prevent just the problem of disease in the first place. Our anatomical barriers, as you mentioned, starts with skin. And it's not just skin. In some ways, it's a few things we don't necessarily think of being an anatomical barrier because it's not outside, it's inside. We know that we have this external and non-specific response. And what do you suppose this means?
So it's just there. No matter what the pathogen is, it's going to have the same.
Yeah, it doesn't really care. It's just a barrier. It's like this wall. It's just a barrier. Stuff can't get through. It doesn't matter what it is. It doesn't care. So it's non-specific. It's not necessarily going to filter out light but let air in. It just doesn't let anything in, right? So that's non-specific. We talk about external, we mean it's toward the outside. Now, you're going to kind of look at that and say, well, wait a minute. Some of this stuff isn't external, like the GI tract. Well, it sort of is. Y'all realize you're hollow? I didn't say you're shallow. I said you're hollow. But there's a hole that goes all the way through your body, comes out the other end, right? Mm-hmm. So really, you're just kind of like this well-formed tube that has been rearranged. Well, keep in mind that there's stuff on the inside of the tube and there's stuff that goes through the middle of the tube. So that is still external when you look at it from the outside environment. So we look at this as it's just barriers that keep things from coming in. We look at it as an epithelial process. It has sebaceous glands. What do those do?
Sweat. Or no, secrete oils.
Secrete more oils and things, which that oil being on the skin actually traps some invaders so it doesn't move very well. We have sweat that actually can kind of help remove things. It just kind of keeps things away. Tears and saliva both secrete stuff out. Tears wash away invaders that might get into the eyes. As long as it can get enough tears to kind of wash it out, it works well. Saliva may actually start to digest some of the invaders. Depending on how it's built, it may break it down. Then we look at mucus linings inside the intestines, the lungs, the GU tract. So these would be mucus things that capture things along the way. Inside our intestines, we have stomach acids, we have mucus linings inside the gut. All those things really prevent bugs from coming across. We also know that in the lungs, there's things in there to prevent invaders from coming across. There's macrophages that climb around inside the lungs and eat stuff. We have a lining inside there that tries to be permeable to pretty much gases, but not other things. The GU tract is the genital urinary system. And there are things there. Men don't have them as often as women because we have a relatively simple genital urinary system. We just simply have the urinary tract that goes up. And it really takes a lot in men, to travel the few inches that it takes to get into the bladder. I'm assuming we're all the same. No one gets that anymore. Women have a very short distance. Once it gets into the urethra, it can get to the bladder at about that far. Plus, there's all this other stuff that can really kind of attract diseases. So it becomes a big problem trying to prevent that. Well, the body has developed mucus processes that kind of help keep those bugs and things from getting away. And a lot of that deals with acid and enzyme production. The female reproductive system is actually so good at what it does that it actually destroys sperm. Sperm that comes in contact with the vaginal lining dies immediately. So it has to kind of find a way past that if it's going to be effective, which is why you don't give one. There's usually, what, billions? Okay, maybe hundreds of thousands. All right, our inflammatory response is a little bit more specific. This is an internal thing. It is an immediate action against invasion. When it recognizes something's there, it does something right now to try to fix it. It's still non-specific because it doesn't know what it is. It just knows, oh my God, something's coming. I better do something about it. So if it recognizes a swarm of bees coming in the door, it would close the door. What's one of the big worries we have about anaphylaxis?
Closing the airway.
Close the airway. The body says, hey, all this stuff's coming in from the lungs. We better stop that. It's not always the brightest system. But that's kind of what it's trying to do. It's very difficult to identify the things on the quick front end. So this is a first response to try to isolate, maybe destroy, maybe eliminate whatever comes in the body from very simple means. It also involves some chemical reactions. And we're going to talk about these multiple plasma protein systems. You already know of one, and some of you actually know it relatively well already. We're going to bring that one up multiple times. It's not one of the ones we talk about here, but it is a plasma protein system. And when we get to it, I'll show you, and you'll probably believe me, maybe. All right, our immune response is a little bit different. Our immune response takes time to develop. You kind of have to have a prior sensitization for this to occur. You have to have been exposed to this invader, and the body responds to that with the inflammatory response first, and then it says, all right, what do I do to keep this guy out again? If you know there's somebody coming in, you're going to start preparing yourself for that thing. So the immune response tries to develop a very specific process to that invader. It knows what it is, and it tries to do something about it. And for the most part, the only thing we really have at work here are lymphocytes. They're going to attack. They're going to do a process called phagocytosis. What's that mean?
Eating of another cell.
They eat a cell. Phagocytes are eating cells. Lymphocytes, leukocytes, macrophages are all phagocytes. And that's what these lymphocytes are going to start to attack these things. Some of them do. Some of them actually work a little different. I'll show you that in a minute. So our three defenses, we have these anatomic barriers that are external, very nonspecific. Our inflammatory response is internal and nonspecific, and then our immune response is internal, but very specific. Okay, it knows exactly what it's going for, and that's all it's really going to do. All right, we are not going to talk much about anatomical barriers anymore. Everything else we're going to focus on is going to be primarily our inflammatory and our immune responses. When we compare these two, the inflammatory response is very fast. Because remember, we said it happens right now, right? Something happens, you start an inflammatory response from the immediate moment of injury. The immune response takes time. First of all, it has to have sensitization, it has to develop whatever it's going to use as a defenders. It's kind of a slower process. The specificity of the inflammatory response, it doesn't care. You're not supposed to be here. We respond. The immune response may look at things and say, you know, you're not supposed to be here, but I have nothing I can do about it. So it just doesn't do anything. If it recognizes it as a problem, it'll fix it. But if it doesn't, it just doesn't do much. The duration or the memory, we don't really get a memory with the inflammatory response. It's like, oh my God, something's happening, and we respond. You can see it 100 times, you'll never recognize it. Okay, this is the system on Alzheimer's, so everybody's new. The immune response has got that long-term memory. And we talk more about it in a minute. You'll realize that some of these long-term memories have been with you since slightly after birth. And it's still there. The plasma systems, again, we'll have multiple ones here. We'll talk more about what these are as we get to them. The immune response really only has one plasma protein system. They're called immunoglobulins. Immunoglobulins is a fancy way of saying antibodies. And then the cells that are involved, we have lots of cells that are involved here. And most of these are what we're going to consider to be phagocytes. The one type of cell that's involved in the immune response, we already talked about the lymphocytes, so that's it. These are mostly white blood cells. These are white blood cells that went to live in the lymph, so they're essentially the same sorts of things. Our concerns are really infectious agents, and some of this really has absolutely everything to do with infectious agents, but not always. You know, your inflammatory response goes to work when you twist your ankle. Every injury that you have involves the inflammatory response, whether there's actually an invader or not. There's an inflammatory issue that goes along with it. We look at it from invaders as a self-defense process. What do we do when something comes in? So these infectious agents we can boil down to really kind of 5 groups. We got the bacteria, which are single-celled microorganisms. You remember what prokaryotes were?
No confused.
Simple cells.
Simple cells. They don't have well-defined nucleuses. You could argue some of them actually have a form of a nucleus, but they don't have the kind we have. They don't have very well-organized organelles. And for the most part, most prokaryotes are a bacterial or a cellulose structure rather than a cell wall type structure. When we talk about cell membrane structure, what's a cell membrane made of?
Phospholipid bilayer.
The phospholipid bilayer studded with the proteins. When we look at prokaryotes, these are more cellulose type structures, which essentially means they're more like a plant than an animal. Plants have cell walls, animals have cell membranes. Bacteria require a host for nutrition because they have to eat something, but they don't necessarily require a host for reproduction and other life functions. They live just fine, and they live everywhere. They've actually found new bacteria in space. That ought to scare people when we bring them back to Earth. We have nothing to fight them. Viruses are a little different from bacteria, and one of the questions that people like to have is, how do you kill a virus? Well, how do you kill a chair?
Take it apart.
Break it.
It's not alive.
That's the point. Either are viruses. We don't really look at a virus under the life definition that we would look biologically. It doesn't quite fit. So when we look at these are what we call obligate intracellular parasites. For them to really be living, they have to attach themselves to a cell, and now they get to have life functions, reproductive functions, and doing all the things they would think of as a living organism. They're kind of like a little cellular cyborg. They're useless until they have something to attach to. Once they attach to, they take over. They can do all kinds of nasty things. Fungi are just yeasts and molds, mushrooms. We have all kinds of different things that fit in the fungi area. For the most part, we'll look at these as vaginal yeast infections, jock itch, athlete's foot. Those are the big ones. They kind of live in places that are kind of moist and warm. What's a parasite?
Tapeworm.
And most people look at this and they want to say protozoan type things, which are usually one-celled animals that get in, like amoebas and things that can cause problems. But you're absolutely right, they can be big. There are people who think tapeworms can get up to 100 feet long. That's an impressive worm you got, isn't it? But those are parasites, and small little worms that get in your body would still fit in that category. They're multicellular organisms that still can wreak havoc. Where you get them depends on where you live, and most of these don't exist in the United States anymore. We pretty much have gotten rid of parasites through one simple aspect.
Clean water.
We have clean water. What's a prion?
Misfolded protein
Yeah.
that aggregates in the brain.
It's a defunct protein, and when you get right down to it, it probably by definition isn't living either. So it's kind of a mini virus. But when it gets in the body, it creates all kinds of interesting problems. Really weird problems. When we look at bacterial diseases, we're looking at things like tuberculosis, leprosy, epiglottitis, botulism. And botulism technically, these are bacteria farts at its worst. They literally off-gas a toxin. Okay, you've probably been in the room with several people who are very close to botulism themselves. So all these different things would fit into the bacterial disease. Viral diseases are things like hepatitis, croup, influenza. The common flu, okay, is a viral problem. Rhinovirus, dengue fever, all these things fit into the viral diseases. Hemorrhagic fevers like Ebola would fit in there. Fungal diseases, and fungus are called myocytes, so these are mycoses things. Again, the vaginal yeast infections, athlete's foot, ringworm, jock itch, a couple of these fancy words if you want to try and pronounce them or spell them. All those things fit into fungal diseases. Parasites would be the amoebic dysentery, giardia, which is another amoeba-borne problem, roundworms, whipworms, what'd you say? Tapeworms could fit in there. The prions is where we find things like bovine spongiform encephalitis. What do you know that as?
Mad cow.
Mad cow disease. Yep. You know why they call it mad cow?
It's easier to say.
Never mind. Would be an inappropriate joke. People don't really get bovine spongiform encephalitis. People get Creutzfeldt-Jakob's disease. It looks almost identical in the long run. They're both neurologic types of dysfunction caused by this defunct protein that's changing things in the body. Kuru is very similar as well. Kuru used to be listed as the world's most deadly disease, because once you got it, you were going to die. Nothing to do with it. We've almost eradicated that by telling the New Guinea tribesmen who were getting this disease to quit eating your relatives. It was actually a disease spread by cannibalism. Not by, the witch hunters in the movie or the headhunters in the movie where they go find the missionary and kill him and eat him. They had a ritual that when someone died, it was considered an honor for the rest of the tribe to eat him. The men got the muscles, the women got what was left, and the kids got what was left after the women ate, because that was the hierarchy. And this stuff usually was found in the brain. So the lower level members of the tribe would eat the brain, the spinal cord, and that's where all this stuff was. So it literally was killing off their children. Because if they died of Kuru, someone had to eat them. It just kept spreading them. All right, so our inflammation process. What do we do as we get inflamed? There's really 4 steps to how inflammation is going to affect our body. The first phase is the acute process. We just have an issue. And let's look with this from a simple standpoint of, I have a splinter. What happens when you get a splinter?
It's red.
It gets red. Well, let's start with, it hurts. The minute that thing goes in there, you know it's there, right? It's not like a week later you looked at, wow, that's starting to hurt. I wonder why. So there's a process right there that says, hey, this is an issue. So we get that immediate process, and it actually starts a healing process right from the start. It starts saying, we have something in the body, it's foreign, I don't like it, we better do something about it. It might move relatively quickly and start healing. If it's a big thing, it's probably going to go to a chronic inflammation where it's just going to take longer for this healing process to begin. And usually this is where it's going to get more inflamed, a little bit warmer. It's going to start bringing more white blood cells to the area to try to take care of it. And one of the things you might notice in this chronic inflammation process, you ever look down at your splinter about 3 days later after you couldn't get it out and it looks like a pimple? Why?
White blood cells.
The white blood cells have attacked. They're trying to eat your little sliver of wood in there. They're saying that's not supposed to be, I better do something about it. So it tracks all that stuff in there. Eventually it might form a granuloma. Essentially it says, I can't eat all this, I'm just going to encapsulate it and hold it so it doesn't cause other problems. You ever have one of those splinters, you can feel it for months later because there's just kind of this knot there? That's that granuloma that's formed. And eventually the whole goal is for it to heal so the body can function normally, do what it's supposed to do. And usually it works relatively well. Most of the time when you twist your ankle, get a splinter, you're usually back to normal within about a week. As long as you don't keep re-injuring, keep picking at it, keep doing silly things. The functions and the whole goal is we want to destroy and remove the unwanted substance. If it's bad for you, let's get rid of it, let's kill it. We can wall off the infected and inflamed area so it's stuck right there. Can't move, can't get worse, it's staying right here. And if we can keep it right here, now we can also bring things to it to help destroy it because we know it's not moving. We want to try to stimulate the immune response. So one of the first things the inflammatory response will do is they'll say, hey, immune response, come here and look at this. You recognize this guy. If it doesn't recognize it, what happens?
It won't do anything.
It won't do anything now, but it'll get ready for the next time, which we'll talk about how it does that in a minute. And again, the fourth thing is that we want to promote healing. The whole goal here is to get our body kind of back to normal. One of the cells that plays a big role in this is what we call mast cells. This used to be a really hard thing to explain because we used to have pants we called mast pants. Anybody remember mast pants? Now we call them PASG. But because we had mast, which was capital M-A-S-T, everyone wanted to spell this as a capital M-A-S-T. Well, they just call them mast cells. I don't know where it got its name. I don't know. Do you know where it got its name? Okay, see, no one knows. It's just a name. It was probably named for Dr. Mast. Who knows? So we look at these types of cells and we know these things play a big role in this inflammatory response. Once the inflammation process begins, these things start to go through a process that we call granulation and synthesization. And they are going to release things, either synthesize it directly or they've already got it stored in granules and we pop those granules and release these substances. And we see this anytime the immune response comes into play, anytime an invader comes in the body, as soon as it recognizes it, this goes into action. We talked about a physical injury, and it could also be a chemical agent contact, which would be a physical injury on a cellular level. We just don't always see it as injury. The degranulation is we have these little pockets that's just building these things up all the time. It's ready to get these things released. And as soon as it gets triggered, it releases these granules. And these things would be our biochemical agents, which we call vasoactive amines. What do you suppose vasoactive amines means? Means?
Works on your vasculature.
Yeah. It does something to the vessels when we release them. And the drugs here are histamine and heparin. Anyone heard of either of these?
Yes.
Yeah.
Okay. Where have you heard of them?
Commercials.
Commercials. Most people have actually heard of antihistamines. We don't hear much about histamines, although that little bug, that little bee, is doing a good job of telling us what actually happens. We should use it in class. The histamines are what make everybody have allergic reactions. They also trigger asthma. Asthma is really just an allergic reaction with a kind of a known cause. So these things are what we use antihistamines to fight, because we use the antihistamines to counteract the histamine response. We'll look at what those do in a minute. Have you heard of heparin? What's it do?
Stops coagulation.
Stops coagulation. So we look at it as vasoactive. It doesn't necessarily do the vessels, it does what's inside the vessels. But it keeps it from clotting. And if we can stop clotting in early phases of healing, that actually is a benefit. Doesn't sound like it would be, especially if you've got a big laceration, but there's a reason that we want it to do that. Chemotaxic factors means that these are things that are going to use chemicals to make the body do something. And here we find things called cytokines. Cytokines are things that tend to draw other organisms to it. It's kind of like putting blood in the water for sharks. It says, here's my problem, come to it. So they're a chemical messaging process. The synthesis, now again, these were, just imagine these things as being just pockets of granules. We get the initial inflammatory response, we release these things. The synthesis is that it has to kind of build those along the way. Yes, sir?
Did you say heparin promotes coagulation or prevents?
Prevents coagulation. Did I say promotes? Okay, no, I didn't say that. It prevents it. When we look at these things, they have to be built on the spot. So it's kind of like it's sitting there ready and it says, okay, what are we going to do? Oh, we need some leukotrienes. We're going to just start building those and release them right away. So they're not stored ready to go, but the components are. So it just kind of builds them and releases them. Nobody knew anything about these until all of a sudden we developed leukotriene inhibitors. Now everybody knows these. They've actually been around for a very long time. They have another name. They've always been SRS-A. That's their other name. It stands for slow reacting substance of anaphylaxis. This is stuff that makes your airway slam shut like that. I always got a kick out of that. It's called the slow reacting substance. Well, what do you suppose the fast reacting substance did? Leukotrienes are going to be released again through synthesis. They're going to cause an increase in vasoconstriction, so they're going to constrict blood vessels. It means blood can't move through that area as well. They're going to increase vascular permeability. What's that mean?
Cells can get out of the vasculature.
They leak. So the blood vessels, even though they got smaller, they spread the cells apart so that it can leak out. It'll leak fluids out. That's why we get a little bit of edema. You ever wonder why someone with allergies gets watery eyes and all this wheezing and stuff? It's because it's leaking stuff. By leaking that out, it also takes maybe this bug, this invader, goes with it. What's the advantage of that?
Gets it out of the body.
It's not in the circulatory system. It's right there. Remember we said we're going to contain it and wall it off? Take it out of the vasculature and it's even better walled off. And again, chemotaxics,
It's going to create a gradient for other cells to follow.
it's kind of like here's my little breadcrumbs, come find me, because this is where the problem is. Prostaglandins are very similar. Prostaglandins are going to increase vasoconstriction, vascular permeability, chemotaxics. But gosh, one other thing that the thing that starts with a P does is create something that starts with a P. Prostaglandins are why you hurt. It sends the signal to the brain that says, we hurt here. It lets it know there's an issue, we need to do something about it. None of these others created any pain. They just started a response. The prostaglandins created pain. That work? Okay, just put the two P's together. All right, in this immune response, we have some of these plasma protein systems. This gets a little in depth in chemistry, or actually this is biochemistry. Biochemistry actually exists. Chemistry is pure mythology. People make that stuff. Some of this stuff actually makes a little bit better sense. When we look at the plasma protein systems, our body doesn't like to do snap decisions. It's not a good idea to say, hey, here's a problem, okay, let's fix it. We don't do that. We have a problem and we say, all right, well, what are we going to do to fix it? And it's kind of like I have to get 7 different people to agree it's a problem before we fix it. So it works from one thing to the next, and then that thing works on another thing, and then that thing works on another thing, and then that thing says, okay, let's do something. Do you remember anything like that? Is there anything that ever was, say, released from the kidneys that went out in the blood and caused something to change to another chemical that went to the lungs and got changed again? The renin-angiotensin system. All right? Y'all familiar with that? Can y'all spout it out?
Yes.
Okay. For those of you who didn't answer yet, you better learn to, because it's important. But that process of that renin-angiotensin system is a plasma protein chain. Again, as I said, we don't like to just say, hey, release us from the kidneys and make you stop peeing. We have a reaction. We have to get a whole bunch of yes votes before the thing actually occurs. Right? That's kind of a good thing in some ways. It could be a problem in others. So these are blood proteins that just float around in the body waiting for something to happen. And this one protein has to get acted on another protein, then it gets converted, then it goes acting on another protein, waits for something to hit it, then it gets converted and goes and acts on another protein. That's the protein chain, okay, that plasma protein system. Their goal is to cause this little chain reaction, we might call it a cascade, and the end result is it stops something from happening or encourages something to happen. It gets to the point in the ones we're talking about here, it destroys an invading substance. Do all plasma protein systems destroy an invading substance? Yeah, what's the renin-angiotensin system do? It doesn't destroy anything. Maybe the bladder leakage. These are what we refer to as delicate and devastating systems because how they work is very important. You have one little glitch in the chemical process that all stops, but when it works right, it can do major damage or benefit, depending on how you look at it. It does require all the inflammatory response to kind of work, and hopefully in the end result, we protect against those unwanted invaders, whatever those are. And the bad part is, out of whack, it can do some damage. All of these things running amok can create big problems. So that becomes a worry. The first one we're going to look at here is the complement system. I will never ask you to draw this chart out. Okay, you happy now? Yeah. I really want you to just kind of think about this stuff and this end result. A lot of this I don't think was studied and kind of put into a relevant fashion. If you look at where some of these things are, we have C1, which is the original plasma protein, got acted upon by the fact that we had an antigen-antibody complex, and it became activated C1, which then came down and found C4, and became activated C4, and then we found C2, and what I think happened was they found C1, they found C2, they realized, wait a minute, there's something in the middle, they'd already named this one, so by the time they got to C3, 4 was actually the one in the middle here. That, or this is a major typo that I've seen in lots of books. But, you know, the first guy copies the second guy, whatever. So I don't expect you to remember where C2 and C4 and all those things come together. That would just be an unfair question. It just doesn't make any sense as a paramedic to even know that. But we do have 2 different pathways that can come in and then activate things, and all it's doing is taking something, becoming activated, that works on something else. So we have this chain or cascade. And what's the end result?
Sure.
Breaks the cell that it was trying to go after. So we have 11 proteins that are down in this process, and the whole goal is to try to destroy this invading process. Now, the complement system, pretty easy to look at. If you look at this and it's not labeled, remember the C is just got to stand for the complement protein. Another one that's important is our coagulation system, often known as the clotting system or the clotting cascade or the coagulation cascade, depending on how fancy you want to be of what they'll refer to it. And we talked a little bit about this earlier, because these are referred to as factors. When have we talked about factors associated with clotting?
Hemophilia.
Hemophilia. What are the 2 different types of hemophilia?
A and B.
A and B. And what's the problem? What's the difference between A and B?
I'm missing a factor.
8 and 12?
8 and
9.
9. And that's it. Now, this one doesn't even have all those on here. We have 7, we have 10, somewhere in here is an 8 and a 9. What we end up with is this process where these factors keep working on each other until we get to the point that we're developing prothrombin and thrombin. Prothrombin is just the precursor to thrombin, it's a plasma protein. If you go to the hospital sometimes, in trauma patients or just other bleeding patients, they may say we need to get a PT-PTT. That's a thrombin and prothrombin clotting time. We're actually measuring how quick these things work. And the whole process is that we're going to try to develop like a fibrin polymer. This is called a clot. It's just a fancy way of saying a clot. So all we're doing is we're building this process going through these factors till we get to some that are actually just named factors. Prothrombin and thrombin are just named factors. they're coming out and causing us to develop a blood clot. Again, we don't clot right away. We have to have this process, a bunch of checks and balances that make us clot. And we talk about there being a problem. What if you are lacking in your blood factor 8 or factor 9?
You don't have a lot.
You can't clot. So what are you supposed to do with somebody who comes to the hospital and says, I'm a type A hemophiliac and I can't stop bleeding?
They give them factor 8.
They give them factor 8. Science is so smart, isn't it? If you're missing it, we give it to you. I'm missing it in case anyone is wanting to get it. All right, our third one is what we call the kinin system. And this one produces a substance called bradykinin. And bradykinin does, wow, have we seen any of these before? It causes some vessels to vasodilate, which means we bring blood into some areas. It causes others to constrict, or other muscles. This is mostly gut. Extravascular smooth muscle means not in the vessels, smooth muscle. So the gut and even the bronchi would constrict a little bit. Increased permeability, meaning it leaks more. And this chemotaxic thing, maybe, sends out signals. Actually, there's several different parts of the kinin system. Some of them do, some of them don't. This is a little more slow than histamine, but that's a good thing. Histamine does it right now. This comes out and keeps it going. You'll notice that a lot of these things have occurred through 3 or 4 different systems. Have you seen that before, where we have several things do the same thing? Like in one test to go in this class. Not the final, but the one before that. Remember shock? What does aldosterone do? Compared to what does ADH do? Compared to what does the renin-angiotensin system do? Don't they all kind of do essentially the same thing in the end result with little variances? So we have a lot of redundancy built into what the body does, and that's what this does. It's just more redundancy. So it's slower, but it kind of ends up doing the same thing. Works with the other factors and other parts of the process, like the coagulation cascade. Our end result is relatively simple. We have a cellular injury. Once we have that cellular injury, so the body's going to respond and say, hey, mast cells, degranulate. Hey, come down here and release all your cellular components. So they'll go through synthesis. And all these things start moving through, activating our plasma systems, getting the complement to clotting, the kinin systems moving. And the end result of all of these is we get some vasodilation. So we bring redness and heat into the area. We have vascular permeability where it leaks, and we'll get edema in the area. You know, why is it that their sunburn looks a little swollen?
Because it is.
It's leaking. Okay, it's just a simple process. Why is it when you get that splinter, it turns red and your finger feels like it's twice the size of the other one? Because it's leaking, it swells. We get a cellular infiltration. We develop pus on the outside. We start to get white blood cells to go get whatever came out. Hopefully we'll get a blood clot if we had a leak. And maybe through one of these, we'll get pain. Which one?
Prostaglandin.
Prostaglandin, coming out as a what substance from the mast cell? Degranulated or synthesized? Synthesized. Prostaglandin is made on the spot. So our whole goal here is to make sure that all these things start to occur. Mast cells are a big part of this. Okay, they start all this chemical reactions. Does that make sense?
Mm-hmm.
Eventually, we'll end up, or occasionally, we end up with the chronic inflammation. And this is where we have a little bit more stuff going on. It's kind of harder to go through. We find neutrophils. Who remembers what a neutrophil is?
Phagocyte?
It's a phagocyte because it's generally what big class of cells is it?
White blood cells.
It's one of the white blood cells. Okay, neutrophils, basophils, eosinophils are the big ones that come out. So the neutrophils are going to degranulate and die. In other words, they're going to release a lot of the substance similar to what mast cells do. And once they do that, they don't live anymore. We'll see lymphocytes start to infiltrate, which means they're going to start leaking out of the lymph system into the tissues. We'll have fibroblasts start to secrete collagen. We'll have pus start to be produced and self-digested. Once pus, because pus is just a collection of white blood cells, right? Well, once they eat everything there, they just start eating each other. So it just kind of goes away. We'll have a granuloma that may form, again, that kind of area that's walled off and just kind of has a knot. Hopefully we'll have some tissue repair and it'll be healthy tissue, but it could be scars. It could be it was so damaged that what happens next is that we just develop big scars along the body. Our local inflammatory responses see some vascular changes. What's exudation mean?
Exiting.
What's a simple word you might know that it does?
Leave.
It exudes. All right, maybe that's not so simple. What's that mean? The what?
Ooze. It oozes out, or
Yeah, it kind of just puts out this stuff. So as it puts out all this nasty junk, it starts to cause a little bit of dilution of the toxins. Maybe those bacteria and things aren't so bad anymore. It starts to bring the plasma proteins and leukocytes to the invading cells, and it does this through what?
Chemotaxis.
Through that chemo. It just, again, that's the blood in the water, the trail of breadcrumbs. It brings the invaders that need, or the attackers that need to get to those invaders. It tells them where they are. And then hopefully it'll carry away those products of inflammation eventually and just kind of clean it out, because you don't want them there forever. In the long run, we have to have resolution and repair of this tissue. It's been damaged, it has to do something. Resolution is when we actually get it back to normal function and structure with maybe some minor damage, maybe some tissue regeneration if it's possible, that it's working. Repair is when we're just trying to get it to the point that it functions. This is where scarring would take place in large wounds. We may develop abscesses or granulomas, and maybe some fibrin remains in the tissues. So this is getting back to being normal as close as we can. This is just saying, all right, it's not a problem anymore. You know, scars are not healthy tissue, right? But it's better than nothing. So that's what we kind of get when we do repair. And hopefully what we're going to do is see this kind of working toward getting everything to go back to a maturation of the tissues. We want it to be strong and healthy in the long run. In reconstruction, we're just kind of rebuilding things. The initial response is we contain the invaders. We seal it off so the wound doesn't get to be a bigger problem. We don't get more invaders in there. The granulation just starts the healing process, growing in of healthy tissues. And a lot of this will kind of degenerate away as the healing actually begins. The epithelialization, what's this word sound like it means?
Making new epithelium.
Epithelialization means making epithelium, which means, okay, let's make skin. Or whatever else it was. They get in through the gut, through the lung tissue. It's going to grow new cells under that scab. Any of you ever have a scab and just kind of pick at the corners of it, and then right around the corner it's nice and pink and fresh? You get a little bit deeper, it starts to bleed. And every week you can get it smaller and smaller. Or is that just me? But you notice that little pink ring? That's the healthy stuff starting to regrow. It actually starts to kind of fill in from the bottom and build its way back up until it's all healed. And all that starts to go through that epithelialization. It's making new cells. It has to kind of start deep and work its way in. And then contraction, well, eventually we start moving so that this becomes a smaller and smaller process. If it heals really good, what kind of scar do we have?
Smile.
A really nice little one, as opposed to a big nasty one. You know, it was always one of those things that if you really want no scar at all, you have to have a plastic surgeon stitch you up, and you may get 100 little bitty mini stitches, but that skin is so tight there's no scar. Or you can have somebody come in and do 3 or 4 stitches in there, you get a really nice scar to show your friends. That's all the healing. How neat and how clean was it as it went through that process? In maturation, this takes time. How do we get all these things to kind of heal? You know, none of you get a cut that's healed tomorrow, right? It takes time, depending on the cut, a couple days, a couple of weeks. Wow, this is a big one. A month later, I've still got little scabs everywhere. So it takes time for that scar tissue start to develop, get remodeled. The blood vessels in the scarring area will kind of disappear, and hopefully that scar tissue is just stronger. Scar tissue doesn't have a lot of good blood vessels. If you cut a scar, it may not bleed much. Mostly because it doesn't have that tissue. It's just kind of a healing process. Sometimes it doesn't work. And there's a lot of reasons why. Why don't you heal? Well, do you have problems with diseases? And one of the worst diseases for healing
Diabetes.
is diabetes. It just doesn't let you heal well. Hypoxemia, where you just don't have enough blood oxygen to go into that tissue and say, hey, I need to heal it. What's one of the things they do for this?
Hyperbarics.
It puts you in a hyperbaric chamber. Would you know anything about that?
Yeah,
Yeah,
just a little bit.
just a little bit. Yeah. Nutritional deficiencies like what?
Anemia?
Like simple vitamins that help heal. You don't have the proteins in your body to build new skin because you decided that you want to be a vegetarian. Which if you look at human teeth, that should never happen. Okay? We weren't designed to eat vegetables alone. A little bit, yes, totally no. Use of certain drugs. What kind of drugs do you think would prevent an inflammatory response?
Antihistamines.
How about any anti-inflammatory? Antihistamines,
Steroids.
non-steroidal anti-inflammatory drugs like, oh my gosh, I have a splinter, it's so bad I better take lots of Tylenol. It's going to work against the healing. There's a lot of other drugs that we'll talk about as we kind of get more in depth with it in later sessions. All right, any questions so far about the inflammatory response and how it works? None at all. You're going to have them, so make sure you ask us, email us, call us, come by, whatever, because it's going to have problems. Keep in mind, you've got to learn all those little, don't know each step in those cascade systems, but understand what they do, understand how the process works, what inflammation is trying to do, because that's kind of important. So as you have questions, get them answered. But other than that, if they don't have anything else, give them 10 minutes.
Class back at 6:59.
I would really encourage you to read the book and then reread that book and get a little bit more information about how some of these things work. It really will help you understand it a little bit better, and then we won't test you to that same level. You know, we kind of had to make a decision how much of this we really wanted to cover in here. If you take anatomy and physiology, you'll get a whole lot more input into things like helper cells and suppressor cells. We're going to try not to get into that right now because really won't make a difference as a paramedic whether you know there was a helper cell or a suppressor cell involved. Help you understand the basics of immunity, it would. When you take A and P, understanding that will help you with some other things. So, as we look at the immune response, keep in mind that this is a secondary response and it has to be triggered. It has to know that it's needed. Remember, the inflammatory response is going to say, hey, immune response, come here and check this out. If it doesn't recognize it, now it's got the trigger, now it's got the sensitization, it's going to say, okay, now I see you, and it's going to start developing a plan of action to get rid of it, to fix it. But it has to have that first thing developed. And what we find is that we recognize antigens, or what we might call an immunogen. What's the difference between an antigen and an immunogen?
An immunogen causes an immune response.
And an antigen just is a foreign protein. So they're really the same thing when you get right down to it, to the immune response. An immunogen just triggers the true immune response. Now, an antigen may trigger an inflammatory response, but won't trigger an immune response. So this one's just kind of a specialized antigen. When we look at how all this stuff works, we're looking at how the body recognizes different tissues. And this is where the histocompatibility locus antigens come in. Histo is the combining word in medicine for tissues. Somebody who's a histologist studies tissues. Okay. If it was a Y instead of an I, a HY histologist would be studying the uterus. Hysterectomies, removal of the uterus. You have to look at the spelling of the word, not just the pronunciation. So these histocompatibility locus things are where we find tissue antigens. Tissue antigens are things that are sitting on tissues that say, okay, I belong here. It tells the body I'm supposed to be there. What does this mean by it's important in transplant?
So your body doesn't reject the...
Yeah, if I give you a heart that was supposed to be for him, because you guys have different blood types, I'm going to pretend and assume at the moment. If you are not the same tissue antigens as him, and we give one of your organs to him, he's not going to do well with that organ. It's going to reject itself, or going to reject that organ. In a sense, of rejection means it's going to
destroy.
It's going to try to eat it. It's going to send all kinds of white blood cells to try to destroy it. It's going to try to wall it off. It's going to try to make a big granuloma with the thing. It doesn't want it there. It sees that it's foreign. So by having the right tissue antigens, we keep that thing. And we see it simply, a blood transfusion is a tissue antigen reaction. It sees that blood is not being there, it starts to affect it. And really, it's just a big fancy allergic reaction. And that's where we see the blood group antigens. What are the blood group antigens?
ABO.
A, B, and really those are them, A and B, because O means
There is none.
you don't have any. A, B means you
Have one or the other or both.
actually have both. A means you have A, B means you have B, AB means you have both. So we just want to make sure that you get the right stuff. Now again, if you have O blood, you could give that to anybody, right? Because you don't have any antigens, that body's not going to recognize as being foreign. If I have A blood and I give it to someone with B blood, that's going to fight. If I have A blood but I give it to someone with AB blood,
You're good?
it's going to say, oh, that's fine. It's not perfect, but it's okay. So it'll take it just fine. And then we have a second grouping. Everyone looks at it and says A positive. That's actually two groupings. Because the A is one antigen group, and the positive means they have a,
RH factor.
okay, and it just means they either have it or they don't. But that's the second process. So they have A blood plus an RH factor would be A positive. When we look at immunities, we can put immunities into a couple of groups. One is a natural immunity. You are just, because of the genetic makeup, because of something about you, you're immune to certain things. Any of you have no allergies whatsoever? Oh yeah, don't raise your hand to get beat up by the others. There are people who have no allergies. Hey, I can pretty much, as long as I don't eat it or lick it, I can pick poison ivy all day. It doesn't bother me. Doesn't affect me much at all. Poison sumac will make me puff up like a blueberry. It's different. I don't have the natural problems with poison ivy. I have big problems with poison sumac. So this is something that's just a natural process. Our immune system didn't generate it. We see some people just don't have the tendency to get certain diseases. We also have acquired immunities that were developed from an immune response. We had to get the problem, the process. And this could be an active thing that requires an exposure and is relatively long lasting. And a good example of this might be chickenpox. You get chickenpox, you had an active exposure. Most part, you never get chickenpox again, right? Sometimes we give it a more passive thing, just kind of a temporary immunity from an outside source. This is kind of what's happening right now with the Ebola thing. They get these people that have the Ebola, they're giving them blood from the people who developed some immunity. We don't know if that's going to be long-term or not, so right now it's just kind of a short-term fix. It's kind of helping people fight it. We also have what we call a primary and a secondary process. The first thing is primary. This comes from that initial invasion. A few days later, we start to release a couple things called IgM and IgG. I'll mention these in a little bit more detail in a second. And these things just go out and start the immune response in that initial invasion. Eventually, they're going to get a memory, and they're going to be ready for that second invasion. They're poised, ready to go, just waiting. And they may never be used, but they're ready if they have to. What is this word?
Amnestic. Anamnestic.
Anamnestic.
Yeah.
What's an amnestic?
Someone who loses their memory.
Okay, that the amnestic means loss of memory. So anamnestic means
You don't lose your memory.
not a loss of memory, which is a fancy way of saying
You
Yeah, remember.
they have a memory. So remember, this is a process that has a long-term memory. It can keep aware of the immune problem and then fight it later. All right, so this is something that's kind of important. You had the chicken pox. In your body right now are antibodies to chicken pox. You realize you have actually gotten chicken pox multiple times since that day you sat in the oatmeal bath and scratched everywhere. Okay, you've had it several times. What happened?
Fought it off.
Body fought it off.
Your body's, I've seen you before, get out. It just destroys it when it sees it the next time. So you're ready for that. It isn't like you won't get it again, it's just you don't suffer for it again. When it comes into your body, and it does every year probably, your body just does something about it. Some's not as good. Flu shot. Why do you have to get a flu shot every year?
Because the strain changes.
They guess.
Strains.
Yeah, it's actually a different flu. The cold is the cold, sort of. we think of it as the cold is the cold. You ever heard that? It's just the cold. It's the common cold, which makes you think that the common cold. Do you know how many cold varieties they've identified?
Hundreds.
Over 1 million. It's one of the reasons why they've quit trying to do research to stop the common cold. It's not common. They try to figure out, okay, how do we get 1 million antibodies into somebody? You have to be a syringe this big. And you know, overall, as you get older, have you noticed you get fewer and fewer colds? Move, and that'll change. As long as you live here, you start getting used to all the colds that are in this area. Move a couple states away, and I'll bet you start getting the colds 2 or 3 times a year again. Because what's happening? The immune system, because once you get a cold, you will never get it again. Once you move, you get a cold you haven't seen that way before, you start getting those colds again. Now, some of them, once you get kind of one thing, it's got a variety that it'll kind of fight, but you still are exposed to it. So this thing with the memory is once you get it, it's supposedly going to be there to fix it forever. We hope. The process and the groups of cells that get involved in the immune system, we mentioned that there's really only one set of cells, and those are lymphocytes. Well, there's 2 groups of lymphocytes. What's the word humoral mean?
Bone marrow.
It probably came from that. But what are we talking about when I say a humor of the body? Fluids. Aqueous humor, vitreous humor. They're the fluids of the eye, right? So when we say a humor, when someone says, you know, a leaking of the body humors, they're talking about fluids coming out, blood and other things. So when we talk about humoral, we're talking about things that live in the fluids and tissues of the body. Cell-mediated means that it really kind of lives in cells or works with cells themselves. So with humoral, we produce B lymphocytes. These are lymphocytes that matured in the spleen and the lymph nodes. B, I don't know where you can put that with these things, but I want you to remember to always be human. Why do I want you to be human?
Because
B cells are humoral.
B cells are humoral cells. These are matured again, the spleen and the lymph nodes. How do you remember these? Well, this one's a T lymphocyte that matures in the thymus. This is NIT, go with the other one. Okay, it's just one of those, pick the other one. These are ones that don't attack antigens. They are lymphocytes. They are by definition a phagocyte, but they don't attack the antigens. They get close and they start bombarding them with antibodies. So they're kind of the antibody carriers that just bring them to the site. What drew them to the site? The chemotaxis. So they knew there was something there if they went that way. These develop memory, and they're always there. They'll come by and then, oh, no, that wasn't you. I'm a cold antibody, and you're not a cold. So it won't do anything. But the ones that are primed for it will then do something with it. The other group then is the cell-mediated. These are called T lymphocytes because they mature in the thymus. These don't produce antibodies, but when they're drawn, they just start to attack the antigen. These are phagocytes. So think of the cell. Maybe you've seen Pac-Man?
Yep.
Kind of looks like a little C that's doing this. That's what he's doing. The C lymphocytes just come along and literally eat things. So think of the C as being Pac-Man and eating up all the cells. So that'll help you remember what they do. The B lymphocyte, or the B humoral, and I always think of this too, B human, the humorals have a B, and they attack by releasing antigens, kind of like little bombs. So what kind of things can you think of that are Bs that drop bombs?
B-52s.
Oh yeah, B-52. How come no one says the B-1 or the B-2? It's always the B-52. Those are impressive airplanes, aren't they? You can talk about a plane that could ruin a country's life. Think about bombers. Okay, B humoral, think of the bombers. B-1, B-2, B-29, whatever one you like, it's your favorite bomber. They are going to actually drop the antibodies, kind of bomb the system. The C-mediated, think of the C in the Pac-Man. They're going to eat. So these are the true phagocytotic cells. They're going to actually drop things, but they're not going to release the antibodies. Or, sorry, eat the things, but not release the antibodies. All right, so we mentioned antigens and immunogens a minute ago. These are what we refer to as the triggers that bring in the problems. So the characteristics are these things have to be foreign. For us to say, hey, this is an antigen, this is going to be a problem. Again, this could cause an immune or an inflammatory response. These have to be there to do the immune response. But for that to happen, the body has to say it's not here. If I give an A positive person A positive blood, does it recognize an antigen? No. I give them B negative blood, so ooh, we got a problem here. So it has to be sufficiently foreign for it to do something about it. It has to be of sufficient size. One of the reasons why things like tuberculosis gets in and causes major problems is it really doesn't come out in big quantities, and it's kind of small. There are people that say it takes one tuberculosis bacteria to cause tuberculosis. It just gets in. And keep in mind, tuberculosis being a bacteria, it doesn't have to have sex to reproduce, does it?
No.
No, it has to get warm and well fed, and all of a sudden it splits into two. So, and then we're off and running. It has to have a little bit of sufficient complexity. If it's a very simple thing, it really doesn't do a lot with it, which is kind of why prions have always kind of been a really hard thing to deal with, and the body just doesn't recognize what to do with them at all. They're not very complex. I mean, what are they?
Misfolded proteins.
Yeah. It's just a protein that instead of going like this, went like that. It's just a small deficient problem. And again, in sufficient amounts, it has to be enough of it for the body to say this is a problem. You know, if I was to just kind of drop a little bit of blood in a syringe that was my blood and I gave it to you and it's a different kind, what would happen?
Get itchy?
Yeah, almost nothing. It's not sufficient enough for anything to happen. You might get an itch at the site. Go away in 10 minutes. Don't go home and test that. I can just say, 2 paramedic students died tonight trying to see if their blood would react. With the humoral immune response, remember this is the stuff that releases which system?
B lymphocytes.
Oh yeah, sorry, I wrote it on there. For those of you who didn't read, you should have known that. This is a process that's going to look at how we are going to defend against this process with the antibodies. Remember, the T lymphocytes are going to eat it. The B lymphocytes are going to bombard it. So we're just going to release these antibodies from the B lymphocytes, and hopefully it's going to take care of things. Now, I mentioned we're not going to say much about the external thing, but there is an external part here. Again, humoral is fluids. We can release some of this stuff on saliva and sweat. It's going to kind of trap and force things out of the body. It does have a role. We're not going to talk much about it. The B lymphocytes, again, produced in the stem cells and bone marrow, mostly in the spleen and the lymph nodes where they're going to mature. I guess that's actually where the B came from, the bone marrow, but then the others really kind of do too. But again, it matures in the spleen and the lymph nodes. When we look at the antibodies, they're going to try to do some things once they find this invader. They're going to try to do a process of glutinization. They're going to make it kind of clumpy. They're going to try to clump everything together, make it into this big antigen-antibody reaction. And it's kind of like what they try to do when the running back has the ball when he keeps running. What's the easiest way to stop him from getting in there? If 11 guys get on top of him and make a big clump, how hard is it for that running back to move?
How hard?
Okay, so next time you watch a football game, you'll run, ooh, glutinization. Changes your whole view of sports right there. Precipitation, well, we try to get it to settle out of the body. If I can hold it and then carry you to the sideline so that you can't go any farther, you can keep running, but we're running sideways out of bounds. Probably much more effective than running all the way for a touchdown. And the neutralization is to just prevent it from binding to the receptor sites. Sometimes these things have to go in, find a site, connect to it, and cause a reaction. A lot of times what happens is you get these antibodies in there and they just prevent it from going in. Well, that's just as good. It's not functional anymore. Our 4 basic things that we're going to try and do. We want to try to neutralize the bacterial toxin. Remember I said that sometimes these bacteria literally off-gas toxic things? Well, if I can neutralize that so the bacteria doesn't prevent these harmful toxins, that works pretty good. So that prevents the binding and makes sure it doesn't function anymore. When we neutralize viruses, we prevent them from attacking and then re-entering cells. So they can't move and get in a cell. If it can't get into a cell, what can't it do?
Reproduce.
Reproduce.
Can't replicate, reproduce, feed itself, nothing. It's still dysfunctional if it's sitting outside of a cell. It has to get in to really have its life functions. Opsonizing bacteria is kind of a interesting thing. It's like putting a nice sugary coating on the cell, on the bacteria. And what's that do? It makes it tasty. It says, hey, this will be the good one for you to eat. So by putting this coat of opsin onto the cell, it promotes that phagocytosis. Now, whether or not it actually makes it tastier to a white blood cell, I don't know if there's any way to see if a white blood cell has taste. But in the long run, it doesn't matter. What it does is it says, hey, I'm functional, I'm digestible, I'm good, come eat me. And then one of the last things is we take that inflammatory process and we trigger the immune system to make sure that we recognize this thing, make sure we understand what it is. In the long run, just kind of make sure that both the inflammatory and immune responses are working at their best. Now, when we look at immunoglobulins, immunoglobulins is a really fun word if you can say it. If you can spell it. So the easiest way to spell or pronounce immunoglobulins is?
Antibodies?
Antibodies, yes. It's kind of like, how do you spell sphygmomanometer?
Blood pressure.
BPCUFF. That's the easiest way to spell sphygmomanometer. Did y'all know that was called the sphygmomanometer? Okay. So when we look at immunoglobulins, immunoglobulin is just a fancy word for antibodies. It's a globule of the immune system. And we mentioned this IgM a minute ago. This is one of the first things that happens. It just starts to respond immediately. It'll have a little bit of an impact trying to get the immune system going. So it's one of the first ones that's produced. It's also the largest immunoglobulin that we see in the system. So these things are big. And I want you to think about immunoglobulin M is massive. Okay, M for massive. What's that help you remember? Big. That it's big. Okay, that it's the biggest one we have. IgG is one that's going to start to develop a memory. It's going to start recognizing repeat invasions, saying you've been here before, we've talked about this, you're leaving. Makes up about 80 to 85% of the immunoglobulins in the blood. So this one, the G, is a good thing for greatest number, because it's the one that's found most commonly in the body. It has 4 subclasses. We're not going to talk about those in here unless you decide to get into microbiology. You'll learn those. But this is where we see the agglutination, the precipitation, the activation of that complement system kind of coming into play. So it has some very important roles. IgA is a little bit smaller than the other two. Really just kind of a couple of quick little links. We find this to be present in body secretions and in blood. So we say it's secreted in mucous membranes, and that's a good place for it to just kind of come out and start to protect those things when they first start to come into the body. IgE is really interesting because what's it responsible for? It's an allergic reaction. So when you watch CSI and they say, man, the guy ate a peanut and swelled up and his IgE levels were really high, what did they say?
An allergic reaction.
He's allergic to peanuts. And for some reason, I keep seeing that. Apparently somebody found that out in Hollywood and they put it in script after script after script. It just kind of rolls. And it'll probably never occur again now that I've said it. IgD is one that we don't see a lot. It's got relatively low concentrations. Usually found on the surface of B cells. Well, a lot of them are found on the surface of B cells. So it really doesn't define it very well. It's just a small amount, usually found in secreted fluids. These work primarily by doing an antigen-antibody binding. And this lock and key model, this is a good way to start it. But we're going to talk about the lock and key model with a lot of other things besides just antigen antibodies. We'll talk about the way hormones start to work. We'll talk about how drug reactions work. Because essentially the body looks at things and it says, all right, this substance fits in this particular hole and causes a certain reaction. If it doesn't fit in that hole, we don't get that reaction. So with the antigen-antibody model, what we're looking at is saying an antigen that has an antibody that clumps around it. And if these two fit, then what happens?
Combine
If this antibody attaches to this antigen, now this antigen can't do the things that these things were supposed to react to. So essentially locks it off. But antibody B won't fit there, will it? So it has to be a relationship between how one works compared to the other, and they're not necessarily interchangeable. So we have to have specific antibodies to specific antigens. And that's what this whole process of developing the immunity kind of does for us. And when you think about that whole process, you know, most of you in here have had a tetanus, diphtheria, pertussis shot, which means you've had 3 antibodies given to you. You've had hepatitis B, you've had varicella, you've had measles, mumps, rubella. You've also had maybe chickenpox, you've had the flu, you've had a couple of colds, you've had other things that you might got, a couple of you've had distemper. If you're in the military and went overseas, you had all kinds of other shots. Keep in mind, every one of those is in your body as an immune process. It's still there. If it's working right, it's still there. So they just develop and kind of stay, and they're ready for the next invasion. Part of the process is we have to start secretions. We have to get fluids out. So when we talk about the secretions of the body, what do we mean?
Sweating,
Sweating, saliva,
crying.
tears, breast milk, urine, feces, all those things could essentially be secretions. These things just kind of help wash these things out. Usually we get these started earlier on tissues like tearing on the eyes. These also could be called our external immune system or our mucosal immune system. It's just a way to kind of keep things out of those areas. The cell-mediated response goes back to the T cells, right? Cell-mediated is going to release T cells, or going to utilize T cells. And these are the phagocytotic cells that are going to eat things. Remember, think of Pac-Man. When we release these things, we're going to develop an ability to go in, find a cell, and just start to destroy it. Again, that memory says it's going to affect repeated exposures, it's going to start to take care of things. Delayed hypersensitivity means that the allergic reaction and the inflammatory response are going to get involved. Hypersensitivity just simply means that it responds quicker than normal. Keep in mind, an allergy is your immune system on higher levels. Every single one of us responds to pollen. We don't all respond the same way. Some of you who are allergic to certain pollens, let's say mountain cedar, when it's high, how's your day? Pretty much, I can't breathe, everything, my eyes are watery. The rest of us walk through like there's no problem. An anaphylactic response is actually a hypersensitive allergic response. So it's just an over-exaggeration of an exaggeration. But it's still simply just a hypersensitivity. Cytotoxicity means that we're going to go out and try to kill a cell. And we're going to kill it in some ways by destroying it. We talked about not necessarily having to know exactly how helper and suppressor cells work, but let's just say that they're important for control, and then tell me how you think a helper and a suppression cell would work in control. And that's all we'll talk about.
Helper makes it go, suppressor makes it stop.
Yeah, and you know what? One of the things that's missing in people with big allergies is your suppressor cells don't always work as quickly as they should. You get the thing that says, hey, it should be there. Oh, it's a lot. Get some helper cells to release more. The suppressor cells can come and go, okay, we're done. That's enough. It's kind of the person yelling ceasefire, 500 shots into one bird's a little overkill. That's all it's doing. But if nothing's there to stop it, it just continues to run them up. So it controls kind of how fast it picks up. That'd be the helper, how quickly it slows down, which would be the suppressors. As we work through the immune system, somewhere along the line we have to identify the antigen through the process. We have to recognize it. We're going to try to ingest it. Again, the T lymphocytes will actually try to eat it. And then break down any of that foreign antigen or foreign substance so that our body works better. In the presentation, that process has to kind of recognize that it's there. We have to get the fragments out. Have we talked about macrophages?
A little bit.
What are they? Where do they come from?
White blood cells?
They were a white blood cell at one time. Which white blood cell? Anyone remember?
Leukocytes?
Monocytes. Monocytes are just those big, immature, it's kind of like baby Huey white blood cells. They just grew up so big, they left the bloodstream, and now they're traveling around in loose connective tissue. They've matured into this other phagocyte called a macrophage. So their job is just to kind of go through and do essentially the same things the lymphocytes do. Again, that recognition, the helper T cells recognize that thing, say you need to go out and get things. They're helping it get going, and then once it gets going, what do we have to have? Suppressors that kind of knock it back down. Some of these things become problems for us in simple fetal neonatal immune issues. A lot of times in utero, babies don't need an immune system because what?
They use moms.
They're using moms. So it's starting to develop. It's actually taking some of mom's antigens and developing them, or sorry, antibodies, developing in themselves. The mom will develop antibodies. Most of the time, these are going to function just fine. They will cross the placental and the placenta into fetal circulation, and this could be a really good thing in most cases. And at birth, those antibodies tend to move with the baby. They may not last for very long, but they're there for a short period of time. Really hard for a baby to catch a cold the first couple of weeks. After that, if you're not careful, you get anything in the world. But it can continue to get antibodies in one way.
Nope.
Breast milk. As long as mom's still making those, a lot of those still do come across in breast milk, which is kind of a good thing. As we get older, our body's immune system starts to degenerate. Why do they recommend kids and the elderly get flu shots?
Because they can get it easier.
Yeah, because they just can't defend against it at all. Very young ones don't have them yet. Very old ones, we've kind of lost that immune system. So as we age, we just don't have the same abilities to function anymore. So the immune system just kind of starts to break down. We just have to do things to try to keep it back up. All right, is that too complicated? No? Should be relatively simple. All right, so let's see what happens when we have variances in it. I mentioned hypersensitivities, and hypersensitivities really are our body responds weirdly to something. Allergies are the best example of it. When we see an allergy, what we really had was some kind of environmental thing that came into our body, and the body says, let's get rid of it. Now, again, every one of us responds to that. It's just some people respond to it a little bit more and have the allergy. And then some people respond to it even more and get true anaphylaxis. Autoimmunity, what's auto mean?
Self.
Self. The automobile is self-mobile, right? So autoimmunity means that these are self-antigens. What's that mean?
Antigens within the body.
Within your body. Your body looks at things and says, that knee cartilage doesn't seem to fit. So I'm going to attack your own knee cartilage. What would you call that?
Rheumatoid arthritis.
So we get this process where the body doesn't even recognize some of its own things. That's what lupus is. Lupus is a broad thing where there's all kinds of tissues, and it varies with the individual of what the body sees as foreign, and it attacks it. You know, one of the worst ones is brain lupus. What's it going to do?
Attack the brain cells.
Yeah, you don't do well with that one. All right, so this is stuff within our own body. What's ISO mean?
Same.
Same. ISO means same. Isosceles triangle has three sides the same. So ISO means the same, and these are other person's antigens. We get the word same from, I grab this heart, I put it in this person, it's the same tissue, or is it? It's cardiac muscle, it's cardiac valves, it's the same blood. But what's different?
Antigens.
The antigens that are on it, we don't recognize as being the same. So that creates a few problems as we try to deal with it. So with our hypersensitive problems, we have this one here, IgE. What do you suppose is going to happen?
Allergy.
We're going to have allergy reactions. Upon a re-exposure of the allergen, we have this massive release of substances from the mast cells. We may actually rupture the entire mast cell, which releases all this degranulated stuff. Histamines, heparins really have a bad day. All the synthesis occurs really quickly. This becomes a big problem, and our major inflammatory response gets triggered. To the point that we have to do things right now, like swell the airway and leak all the fluids out of the body. So you find people that have watery eyes, can't breathe because their larynx is swelled up, they're puffy everywhere, their lungs are full of fluid, all because they sniffed a flower that had a little more pollen in it. Or there was a bee in it. So we see these people with skin having flushing, itching, hives. What's hives?
Little red spots,
Just little raised, guess what that really is?
swelling.
It's swelling. It's a fancy form of edema in just small pockets rather than a little bit of everywhere. The flushing is the vessels, just kind of as they start to dilate to push things out, we start to see everything get red. In the respiratory system, we might see that breathing difficulty from edema inside the laryngeal areas, inside the alveolar areas, some laryngeal edema, maybe spasms, maybe some bronchospasms. A lot of this stuff, these two especially, are same kind of things we see in asthma. Here it just all of a sudden stopped without warning, or started without warning. In the cardiovascular system, we get vasodilation, that increased permeability, which again means we leak. We get an increased heart rate to kind of push things through the body faster and hopefully trap it faster. We'll see an increase in blood pressure initially. When will we see it start to drop?
Is it decompensated?
Why would it decompensate?
Because it's tired. I'm not.
That's a good answer, but you're only a third of the way there. Why are we decompensating? What have we lost?
Volume.
Fluid.
Where did we lose volume?
It went to the interstitial space.
It leaked, right? As this permeability causes worsening edema, it's not in the vasculature anymore. If it gets bad enough, this will drop. That's how we have anaphylactic shock, is we've actually lost fluid, not from the body, but from the vascular space. It just shifted. It's all still there. And which makes it a problem is if you fix all the shock and you still have the fluid out, what happens when it comes back?
Hypertension.
Now we have a different problem. Yeah, the pressure's going to go up. In the GI system, we might see nausea, vomiting, some cramping, some diarrhea. And I finally fixed that because for years the M was missing.
Camping.
Just a little embarrassing. In the nervous system, some dizziness, headache, convulsions, some tearing. In other words, the watery eyes. In our type 2, here we have tissue-specific reactions. The immune response against tissues that are on some of the body tissues. Like what? Like an autism thing, right? This is, I don't recognize you. In type 3, we get the immune complex mediated process. That's a big fancy set of words there. But here we develop this antigen antibody complex associated with blood and body secretions to a specific antigen. We're actually fighting one particular thing. Not like allergies. We actually know what the problem is. We're looking at this as a problem with maybe a single isolated organ. Just starts to create problems in one little area. This could be associated with diseases like Raynaud's disease. You ever seen anyone with Raynaud's? Anyone know what that is? This changes the circulation of the body, usually in distal areas. You find someone's got Raynaud's disease, their hands, usually their feet too. Most of the time we don't look at feet. They start to get really pale, almost albino. And it's just they're constricted so much they're not getting any blood flow into those areas. So they'll be cold and really kind of look almost fake. We also can get arthritis reactions, which will get skin problems, or if we see that from skin problems where we're just starting to develop just kind of little raised areas. Think about this as a positive TB test. That would be a skin response that would create those issues. A GI reaction to wheat products, what do we know that is now?
Gluten. Celiac.
It's caused by gluten, but it's the celiac disease, which I think is the most overdone thing. I know people who, I'm on a gluten-free diet. Why? Well, it's bad for you. Only if you have celiac. I mean, absolutely nothing. And you'll find all kinds of people, oh, it's better diets. It's better not that. Yeah, you can reduce your carbs a little bit. That might help with the waistline, but that's really not the issue. You can do the same thing by eating half as much bread instead of just going gluten-free and still being a pig. All right, type 4 is the cell-mediated issues. Again, cell-mediated meaning the T lymphocytes are going to be released. don't involve antibodies because they take
Lymphocytes.
the B lymphocytes. And this would be things like graft rejections, responses to poison ivy, other types of poisonous things like sumac and oak. And that brings us to deficiencies. What kind of things happen when we don't do this very well? Which would be another good point for another short break. Anybody have any questions? Isoimmune conditions?
Yeah.
ISO.
Okay, let's go with the one that has isoimmune in the word. Okay, isoimmune neutropenia just is a problem where our blood reacts to an external source of essentially white blood cells. This one also would be a problem of an isoimmune system. It actually still has it in the name. RH and ABO, what's that refer to?
What type?
Blood type. So the rest of these are primarily autoimmune diseases, things like Graves' disease. Anyone know what Graves' disease is? Graves' disease is a thyroid dysfunction. And essentially your body says, well, your thyroid doesn't work the way it's supposed to, and it just causes havoc with your thyroid. Rheumatoid arthritis, we talked about that, just it's a body rejecting its own joints. It usually has to come about through rheumatic fever. Myasthenia gravis, you ever heard of that? So what is it? It's one that everyone's heard of, right? We don't know what it is. Essentially, it's a problem of muscles. When muscles start to get weak very, very easily, it can be classified as one of the muscular dystrophies, but by definition, it doesn't quite fit in there. Immune thrombocytopenia purpura. What do you suppose one of the symptoms of this is?
Skin
Purpura.
You can't
Purpura.
clot.
What's purpura?
Skin lesion.
Yeah, big petechiae. Does that help anybody? Little red spots, just bigger ones. This is a problem of, what do you suppose thrombocytopenia is?
Clotting? Something like clotting? A red blood cell.
Thrombocytes are, you guys keep saying clots, but you're not getting the cells that create clots. What are those called?
Platelets?
Platelets. Oh, there we go. Boy, that took a lot longer than that. Thrombocytopenia is a condition of platelets. That because of the fact that we don't have good platelets, we don't have enough of them,
Yeah.
we start having little bitty disruptions in the skin. And we mentioned lupus the other day. This is, or I guess 10 minutes ago. Systemic lupus erythematosus is the real name for lupus. And this is just a condition where our body would look at things and say, you know, I don't know that all these cells need to be here. And yet it will pick them. It may pick brain cells, muscle cells, nerve cells, and it just kind of starts to have problems with it. People who develop lupus may have problems with blindness, with hearing, with kidney dysfunction. Could really develop anything. So these are all issues where our immune system has done what?
Attacked the body.
Protect
Hey,
itself.
so it's actually gone into a higher level, right? So one of the ways to fix some of these is to decrease the immune response.
Can you explain the isoimmune diseases again, real quick?
Of what they are,
Yes.
the isoimmune neutropenia is just a condition where we break down, usually occurs because we had to get the neutrophils from someone else, another one of the white blood cells. So it just starts attacking those things. Or isoimmune is same, so it had to come from someone else, can't be yours. The RH and the ABO is the RH factor, positive or negative, and the A or B, and I always like ABO blood type, and it really isn't an O blood type. It's an absence of an A and a B blood type. But I guess that makes it a blood type. It's just not an antigen. But this is, we give somebody the wrong blood type, and what happens?
It attacks it.
They really just have a big allergic reaction. It's a mean, nasty allergic reaction. That's really all it really is. Major histamine is. If it's just a mild one, you give them some Benadryl and let them ride it out. If it's a big one, you have to remove all the blood and all the blood tubing and kind of start over.
Wouldn't enough of the wrong type of blood cause blood clots? A lot of them?
It's a possibility, but a relatively rare one, because really what the bigger problem is that it actually starts to destroy those red blood cells, so there's really not enough blood stuff in there to clot. It can be a problem kind of going the other way, rather than clumping all that stuff, it's just going to destroy it. All right, so this is our immune system kicked into higher gear. A way to fix this is to decrease our immune system by just putting them on immune suppressant type of drugs. The other one is acquired immune deficiencies, and this means we don't have the immune system present in the body. And this could come about from nutritional deficiencies. You just don't eat enough to get the proper elements to make an immune system work. And essentially, it's a malnourished issue. Anyone ever seen this word, iatrogenic deficiencies? Okay, besides you, has anyone seen it? If I told you that iatrogenesis was the 7th leading cause of death in this country, would that help you? It'll worry you when I tell you what it is. What is it?
From healthcare.
Yeah, it originally started out as physician-induced. Isn't that amazing? The 7th leading cause of death was physicians. But sometimes they make mistakes too.
What that means?
Iatrogenesis started off meaning physician-induced. We've kind of adapted it now to mean healthcare-induced. So if a paramedic killed someone, it would be an iatrogenic process. But when I talk about iatrogenic deficiency, I just mentioned one of these that we actually use it beneficially.
Immunosuppressants?
When I have these problems, what's the easiest way to fix it?
Immunosuppressants.
Lower the immune system. What do you do for everybody who gets a kidney transplant, a heart transplant, a lung transplant, a brain transplant?
Immunosuppressants.
We put them on immunosuppressant drugs so their body doesn't reject it. So that's an iatrogenic deficiency. It works great at making sure that your kidney's not rejected, but what's the problem with it?
It kills your immune system.
Yeah, you can't fight the other things that come along either. So you have to be real careful about how you take care of yourself. We can have deficiencies caused by trauma. Deficiencies caused by trauma could be that, oh, I don't know, we hurt the bone marrow so much that we're not even going to make more red blood cells. It could be that we just have so much work doing in healing that we're not going to be able to heal or prevent other infections from coming in. Deficiencies caused by stress. Anyone ever notice that when you're stressed, you just get diseases quicker? There's a lot of studies that show if we could just keep people from getting stressed out, we would have very few medical problems. Stress is a big problem. Stress, by definition, reduces our immune system. So we're more likely to get diseases and get other conditions. And then, of course, we have this thing. You ever heard of that? Acquired immunodeficiency syndrome? It's the result of an HIV virus. It actually breaks down your ability to fight diseases. And really not a whole lot we can do about it. Now we're able to actually make people live relatively long lives with it. Actually, what's the biggest cause of death under acquired immune deficiency syndrome?
Pneumonia.
Pneumonia. Why?
They can't fight it.
Anything comes in their lungs, all of a sudden starts a colony, yeah, they can't fight it. Where do they get it from?
Iatrogenic sources.
People's. And a lot of them is physicians. One of the things, people are always afraid, oh, I better wear my gloves and my gowns and all, I don't want to get AIDS. AIDS patients have more to fear from you than you have to fear from them. If you have a little cold that you even know about yet and give it to them,
Kill them.
you could kill them. So that would be a bad thing. We try to not to have that. Replacement therapies really kind of fall into both good and bad things. We know that occasionally one of the things we'll do for people who are having rejections is give them some gamma globulin therapy. It's just a process of giving different types of immune developing systems or substances. We know about transplantation and transfusion. What are our problems here? What do we have to do with those people?
Suppress their immune system.
We have to suppress their immune system. And you know, we suppress our immune system all the time. We don't even think about it. Every time you have an allergy and you take an antihistamine, what do you do?
Suppress your histamine.
You suppress the histamines and sometimes the other stuff, so you suppress the system. When you have a headache and you take an aspirin,
Keeping it
Anti-inflammatory.
anti-inflammatory.
it's got some anti-inflammatory properties, right? So if I'm reducing the inflammation, I'm suppressing my immune system at least a little bit. So keep in mind, anything that's considered an NSAID. Have you ever heard of NSAIDs? Other types of pain medicines, they're called non-steroidal anti-inflammatory drugs. Steroids are all anti-inflammatory. These are anti-inflammatories that are not steroids. So they are going to reduce that process. We also have some gene therapies. Gene therapy could really be a beneficial thing in most cases, because what are we trying to do with gene therapy?
Alter a gene.
Sure, we take a gene and we say, all right, we're going to make you less prone to this problem. In a perfect world, it'd be really nice to just draw out somebody's genes, figure out what their code is, figure out, you know what, you got a weakness to peanut allergies. Because you might be missing a gene or you have a malfunctioning gene. If we just give them that gene, what would happen?
It wouldn't be allergic anymore.
Yeah, wouldn't that be a great thing? Well, we're thinking we can do some of that. And you ever watch these TV shows where they were able to genetically make laboratory mice that had a problem? I always get a kick out of that. We made laboratory mice that get cancer if you whistle at them. That's somebody who has way too much time on their hands. But if we could alter some genes to be really beneficial in the immune system, make it work better or make it work less hypersensitively, then it would be a benefit to those patients. All right, lastly, let's talk about stress and disease. What did I say about stress and disease?
Lowers your immune system.
That they're very highly related. Stress is a very interesting thing. When we look at stress, stress is a normal response to a physical or psychological arousal and stimulus. Anytime you get aroused in any kind, good or bad, you have a stress. Okay, you may not think so, because sometimes it's a good stress. Someone gives you a Christmas present, you're aroused, but that's a good stress, right? Sort of. You have that all the time, it's still a bad stress. There is always a little bit of stress present in some degree. You always have a little bit of stress on your body. Nobody is perfectly comfortable all the time. We're just always under just a touch of stress because everything's unusual. How many of you like horses? You ride horses a lot?
Sometimes.
What happens if you ride a horse that you ride every day down the same path every day and all of a sudden someone cut down a tree or planted a new one? That horse will freak out. They're the dumbest animals you've ever seen. But they'll walk along, oh, someone trimmed that tree, and they will freak out. They are so skittish and stressful, it's just amazing to me. We have people like that. Every once in a while, I probably shouldn't tell you because I like to do my little psychological experiments. Every once in a while, I'll walk in here and I'll take one of the rows of desks out. Because the people who come in from the back door will count 4 rows up. The people who come in from the front row will count 2 rows back. And eventually you get to the point, wait a minute, I'm not supposed to sit next to you. No one looks and says, oh wait, I'm in the 5th row of 4. They just count, I'm this far back or this far up. And it's just amazing how much that affects people. People are odd animals. You know what happens if you just take a flashlight and stick it on the table? And one person walks in the room?
They'll grab it.
They'll grab it. If there's another person in the room, they'll turn on and shine it in their eyes. You know what they'll do if there's no one else in the room? They'll shine it in their eyes. If you ever just get bored and want to do that, just take a flashlight, stick it somewhere, and then sit back and watch people. It's just amazing. If there's 2 of them, if there's just one, it's them. And they can't figure out why they can't see you to get their way out. In the response to stress, our body goes through some basic stages. These stages, and I wish these things added up, the general adaptation syndrome, which we call GAS, does not add up to these 3 stages. So you can't say, well, what is the general adaptation syndrome? If I on a test, I say, what are the stages of GAS? Don't say, well, let's see, genital, adrenal, you can't figure it out. We use the term gas. It isn't one of those things like APGAR or sample. Doesn't mean something. We just have to know that there's 3 stages to the gas process. The first stage is the alarm. All of a sudden you realize, oh my God, someone put a flashlight on the table. Your first thing is to run away or shine the light. One of the 2. You have essentially this fight or flight mechanism which tells you what system just kicked in. Sympathetic. Oh my God, a lion. I better fight it or run away. So it's so unusual, we're not sure what to do yet. The second stage is resistance adaptation. When you get to the point that you have coping abilities, that you're able to kind of figure out, okay, what do I do about this lion? How about if I just close the door and don't go in the room? You end up coping. Is the lion still there? Is it still a problem? but you found a way to cope. You're dealing with the lion. This could be the last stage of stress if all of a sudden there's nothing I need in that room. Let's just wait till the lion's dead. And it's decomposed completely because there's nothing worse than dead smelling lion. So just board the thing out, the next generation can deal with it. If we can't resolve it here, there are people who can't. We go through the final stage, which is exhaustion. And exhaustion is when we have been coping and coping and coping and coping and coping and coping, and I just can't cope anymore. Now we get burned out. We've lost those coping mechanisms. It's like there's something I need in that room and the lion's still there. You're stuck. You've got to find a way to deal with that thing. And this is where we usually see physical illness start to come into play. We are so stressed, our ability to maintain a healthy relationship with ourselves has been lost. We see these in a lot of people. Whatever that little coping mechanism, whatever their problem is and how they deal with it, and then the exhaustion phase kicks in relatively quickly. Some people it takes a long time. Just depends on the individuals. As I mentioned, that first stage is really a process of the sympathetic nervous system. The sympathetic nervous system kicks on the endocrine system. The endocrine system kind of works with the immune system. So all these things tend to come into play at the onset. We know that we start with a stressor. Oh my God, a lion. Our central nervous system is going to have a response to that, and it could come about from psychological responses, could be from the true sensor itself. If I just tell you there's a lion in the room, most people won't believe there's a lion in the room. If I said, don't go in there, I think there's a snake on the floor. 3 of you will rush in here because you want to play with the snake. The rest of you will faint. I've actually had students who talk toxicology. I show a picture of the snake, I'll hear them go pass out dead on the table. Hopefully not dead, just out cold. So one of these two things comes along, triggers our our central nervous system. The central nervous system is going to hit the hypothalamus, and we're going to release a hormone called corticotropin releasing factor. That's not going to do anything except one thing. Release corticotropin. That's it. A chain response. Doesn't cause one thing to happen, it causes something that's going to cause something else to happen. Remember, we like those redundant kind of systems. And when we release that, our sympathetic nervous system and our endocrine system are both going to get involved. All right, we're more comfortable with the sympathetic and the fight or flight mechanism. So let's start off by saying we release norepinephrine. We're going to release a little bit of epinephrine as well. So both of these things are going to be released. These specifically from nerve ends. These both come from the adrenal gland. These are going to come out and will start an effect on the immune system. The endocrine system, again, we're going to have the corticotropin releasing factor come out. We're going to start releasing corticosteroids from the adrenal glands. These corticosteroids are going to, in some ways, really kind of help us develop immunity to some of this stress. And again, bringing out, we're going to affect the immune response along the way. Now, you probably can't read this on your little handout thing, but it's in your book in color. So that would be a thing. Open book and look for this. Our neuroendocrine regulation is kind of what it sounds like. It's the process of how our nerves release hormones. Hormones are part of the endocrine system. The sympathetic nervous system is going to be stimulated by that corticotropin releasing factor. It's going to start working on the cortex of the adrenal glands. It's also going to affect the medulla where these other hormones come out. And it's going to stimulate the release of the catecholamines. What are catecholamines?
Epinephrine.
Yeah. For those of you who are picky, a catecholamine is a cattle group, or a cholamine with a cattle group on it. For those of you who want to know exactly what it is, it's epinephrine, norepinephrine, dopamine. Those are our 3 natural ones. Dobutamine and isoproterenol would also fit in that category. They're just essentially hormones that come out that are going to stimulate and work in the sympathetic system. We're also going to see a hormone come out called cortisol. And cortisol is actually a beneficial, is that a word? Beneficial hormone in the process of stress. It actually is a good thing to have during stress because it reduces how the stress actually bothers your body with kind of a little buffer layer. A few other hormones come out, insulin and glucagon come out and give us our sugar levels so we can maintain our energy levels. When the catecholamines go out, they trigger that fight or flight mechanism. And this gives us all the stress response things that we think we normally get. In the brain, we get an increase in blood flow. And again, where do you suppose this chart would be? In bigger things? Yeah, in your book. In the brain, we get an increased blood flow and increased glucose metabolism. What's this mean?
More energy.
More energy in the brain. In theory, we can think better because we make sure we get a good blood flow. And stress is important to think good. Yeah, very important to make good decisions then. In the cardiovascular system, we increase the contractile force and rate of the heart, and we get peripheral vasoconstriction. These things sometimes don't sound right. This is, I want to push blood farther and faster, make sure you're getting everything. Why would I vasoconstrict in the periphery? Yeah, well, mostly here we're talking about skin and tissues I don't need. I only need that blood going to some internal organs and muscles. Heart, kidneys, brain, and muscles are the only things that really need a good blood flow and stress. When I'm running away from that lion, I really don't need to think, digest now, digest now. It's not a good thing. You know, oh, that skin just needs a good blood flow. You can get that later. In the pulmonary system, we get an increase in ventilation. We'll breathe a little deeper, a little bit faster. Bronchodilation means we're going to
Open up the airway.
and get more air in, which is a good thing. We also will have an increased oxygen supply. Why?
Get more air.
More energy. I'm going to get more oxygen supply there because of the increased oxygen demand in the muscles and other organs that are going to be involved. In the liver, we haven't talked about a lot of these different effects yet, but we're going to see an increased glucose production. We're going to see an increase of gluconeogenesis. If you don't know what that is, don't worry about it yet. Just know the word. Glycogenolysis, glycogen synthesis, all the things that relate to sugar. So we're going to use our liver to take stored sugar. We may even make more sugar simply so that we have more energy. Because when I'm running away from the lion, I probably shouldn't get halfway there and go, now I'm just bait. You don't want to. Gastrointestinal and genitourinary systems, we have a decrease in protein synthesis. We actually have a decrease in movement altogether, which is kind of a good thing. Running away from the lion, stop a minute, I gotta pee. You don't want to do that. In the muscles, we have increased glycogenolysis. We're breaking down some of the complex proteins or complex sugars. We get increased contraction, so the muscles actually work harder and work better. We get increased dilation of the skeletal muscle vasculature. By dilating the skeletal muscle vasculature, what's happening?
More sugar, more oxygen, get rid of the waste.
More blood flow, yeah. The good stuff's coming in, the bad stuff's coming out faster, which is very important, again, when you're running away from lions. The skeletal system, we have a decreased glucose uptake. Again, what kind of role do our bones really have in running away? Stay connected, keep pulling on the muscles. We don't really need them to think a lot. We don't need them to do a lot. So we decrease a lot of the things it does. In the fatty tissues, well, this is one of the things that's really kind of weird. You actually get fatter under stress. Okay? Cortisol will help you get fat. Now, in the initial stress response, it's going to actually increase what's lipolysis or lipolysis.
Fat destruction.
Okay? It's going to break down fat. What's it going to do?
Use it as
What's it going to use that fat for?
energy.
Energy. We're going to actually help find a way to turn it into sugar. Now, in the long run, all this stuff actually gets set. If you're not running away from the lion but still under stress, you're just sitting idle, all stressed out,
You get fat.
you get fat. Cortisol helps you build up fat layers if you're not using it for other things. So that's kind of a decrease. In the skin, we get a decreased blood flow. We talked about that with the peripheral vasoconstriction. Lymph tissues start to kind of have a problem just kind of breaking down proteins, and we may not necessarily want to have that all the way, but it's kind of good to have some proteins available to us. Cortisol, in that other hormone that comes out, has some really important functions. In the carbohydrate, what's carbohydrates?
Sugar.
Sugar is the simplest carbohydrate. We have more complex ones. But it's going to make sure that we use this better, that we are able to get sugar into the muscles. And one of the things about insulin that people don't realize is that you don't need insulin in active skeletal muscles. Everyone's always taught that insulin is important for getting all the sugar into the cells. That's true. You don't need it to get into brain cells. It goes into the brain cells just fine without any insulin. And you also don't need to get it in active skeletal muscles. So if you have that DKA patient and just have them run behind the ambulance all the way to the hospital, they'll probably have a lower blood sugar by the time you get there. Not that I recommend that as the principal therapy, but it would work. And actually, if you're a type 2 diabetic, how do you maintain your sugar?
After diet,
Diet and exercise. You get a certain amount of energy or a certain amount of exercise every day, your blood sugar will start to drop. We also have to get proteins taken care of. So again, the cortisol will help us develop the protein metabolism a little better and be protected that way. Our inflammatory effects get changed a little bit. We decrease some of the lymphocytes so that we aren't fighting off some of the things that are there. We decrease macrophages, eosinophils, decrease leukocytes. What does this do for us? Or do to us? If I don't have these things available,
Your immune system is suppressed.
my immune system really doesn't work. So what do we say about the immune system? Stress affects it, right?
Mm-hmm.
So when I have this stress, when I have lots of cortisol in my body, I may be more prone to diseases because I just can't fight that off. We look about those stages of shock or stages of stress. When I get to that exhaustion point, I have it all the time, I can't cope with it, I've really kind of lost control of my stress. I start to get sick because I just don't have an inflammatory process there to help me. Really, I see a decrease in my immune reserves as well. They kind of go down too. I mentioned the lipid metabolism, that we increase lipolysis in extremities at first. We also get lipogenesis in the face and the trunk. What's that mean? Lysis is breakdown, genesis is creation. Just like the Bible, Genesis, creation story, right? So we're creating fat. So you see people with a lot of stress, they're going to have a different body shape. You know, you got fat guy, and you got, wow, that fat guy's got the skinniest arms and legs I've ever seen. Why?
stress.
It's more of a stress fat. Their body just lays it down in different ways. Some people are just built funky, but it could be a potential. Digestive functions, we're going to decrease the increase gastric secretions, which is something that's really kind of common with people. When they get really stressed, what do they sometimes get?
Yes.
And ulcers. Okay, most ulcers actually come from a bacteria, but we know that this always causes this gastric secretions. More often than not now, we're getting more things we know better as GERD. You know, we always talk about in stress, you'll get an ulcer. Well, it was an assumption because we knew this happened. We just didn't realize what the real cause of ulcers were. So now we look at it and see, we're just gassy. We may pass gas a lot. We may develop things like the GERD, what is GERD?
Gastroesophageal reflux disease.
So essentially your upper part of your, or lower part of your esophagus opens up and stuff kind of pops up and it just irritates your esophagus. Really it's more of an esophageal problem than a stomach problem. Urinary function, we enhance production of urine, which probably you're going to decrease it with the stress hormones, the catecholamines. This just means we're going to increase it. Connective tissue functions. What are connective tissues?
Ligaments.
Hold stuff together.
That cartilage, ligaments, tendons, technically blood's a connective tissue. But these are going to go through a process, where was it on my line? What are fibroblasts?
Cells that make collagen.
Okay, so we're going to, if those things are not functioning in the right way, we are going to have a problem of just healing. So if you have a lot of stress on your body following the injury or some kind of illness, it's just harder to heal, harder to get the process going. Muscle function tends to have some problems with just kind of working normally. We have normal contractility and output of skeletal and cardiac muscles for the most part, but we may have a function somewhere else in smooth muscles. They may not work as well. Where do smooth muscles come into play?
GI tract.
GI tract and
Vasculature.
vasculature. So even though for this it's kind of protective, when we say it's maintaining that stuff, it's a protective thing to make sure heart and regular skeletal muscles are okay. But we need those, right? If I'm running away, I need to have a strong heart, I need to have strong muscles. I kind of sacrifice the smooth muscles to get that. When I look at bone function, I keep thinking bone, it's kind of so important to talk about bone function. It decreases bone formation. All right, how many of you need, at this time, right now, running away from the line, I better build some bone? It's not the major function. It wouldn't work. If you had a broken leg, it wouldn't heal as fast if you're on cortisol, but in the stress response, it's probably a good thing. Cardiovascular function, again, it helps us maintain normal function. We get that normal blood pressure in stress in most cases. We'll get some arterial constriction, myocardial function, in other words, the heart continues to work right. Central nervous system, which is all the brain and the spinal cord. We start having problems with functioning, daytime arousal under a lot of stress. It's hard to go to bed at night. It's also hard to wake up in the morning. Part of that has to do with how the cortisol is sitting into your body. Some of the other hormones that get involved, and we talked about some of these things a minute ago. We regulate the process of the adrenocorticotropin hormone, which comes out of the pituitary gland and says make some corticotropin hormones. We inhibit, or can inhibit under sometimes, the corticotropin releasing factor. And if we inhibit it, what happens? It stops. We don't put out some of those things. So under long-term stress, it actually could go the other way. The initial stress responses release it. Long-term stress, it tends to take it away. Growth hormone gets released, and a lot of people, it just gives us muscle strength, gives us ability to heal. What's prolactin do?
Lactate.
Yeah, in women, it has a much more effective role than it. Men produce it too. It really just kind of helps with some muscle strength in general, but it's in relatively small quantities. Here's an important one for most men. The more stress you're under, you ever notice that when you're really stressed, your voice gets high? Probably not directly to that, but kind of makes the point. Overall, long-term stress, men become less manly. I mean, you really are. What makes men men? Testosterone. Remember, they could have been a boy. Prior to being a boy, you didn't, or when you were just a little boy, you didn't have testosterone. That's why you didn't have facial hair and other types of body hair. When you become a man, it starts to come back. Well, if it starts to decrease, you got to go back to that boy stage. You just don't produce things. Things could be rough on you. As we look at how all these things kind of come into play, this is kind of a big, long, drawn-out process that as you look at it, the circles kind of come back around this way. And what's that trying to tell us?
It's a
That if we
never-ending
can't stop
process.
it keeps getting worse and worse along the way until we finally go through a point where we have exhaustion. There are some theories that suggest you can be so stressed that you can die from it. I'm not sure we'd get that far. I think something would probably stop in most cases. Or maybe you just die and that's what stops it. We see all this stimulation of the hypothalamus producing the, what's CRF?
Corticotropin releasing factor.
Okay, so it's making corticotropins. This stimulates the pituitary gland to make the ACTH. The ACTH goes to the adrenal glands, produces the cortisol. The cortisol suppresses the immune response, which produces macrophages, which secrete cytokines, which stimulate the hypothalamus. And we just keep going like this until we finally stop the process. Whatever it takes to stop the process. If that lion would just leave, we'd be fine. Those damn lions. So overall, when we look at stress, stress can lead to a whole lot of different diseases. In the cardiovascular system, we know that stress worsens coronary artery disease. What's coronary artery disease? Well, have you heard of atherosclerosis? That's what causes atherosclerosis. It leads to MIs, angina, heart failures. Really, it's the precursor to all the things we think of as being bad in the heart. So you can be stressed so bad you don't have a heart attack. You could have hypertension, strokes, dysrhythmias, and everyone looks at dysrhythmias like, oh my God, what would the heart do? What do you suppose the most common dysrhythmia is under stress?
AFib? Tachycardic?
Tachycardia.
Wow.
Heart rate goes to 101, you all of a sudden have a dysrhythmia because you're tachycardic. So don't think of it as, oh my God, the heart's doing some fancy little jumps and deeps and funky. Could just be a fast heart rate. The muscles, we can create tension headaches, muscular-related backaches. Those things never occur, do they? Connective tissues could have really kind of worsened rheumatoid arthritis. People who get under stress can actually have worse cases of rheumatoid arthritis. My mother has it relatively bad. She gets a cold, and arthritis is worse than the cold. She doesn't mind not breathing. She just doesn't like not being able to move because she's pretty much gone. The pulmonary system can be affected by things like asthma and hay fever. Immune system, well, we can get some of these different immunosuppressive issues. Gastrointestinal systems, we still list ulcers, even though most people have said ulcers come from the Helicobacter pylori virus, or I'm sorry, bacteria. We still think that it really has a role somewhere. Maybe it just means that it overwhelms the system so the bacteria has a place in, but we know there's a connection somewhere. Irritable bowel syndrome just means what?
Gassing.
Your gut gets queasy. You get gassy, you may have diarrhea, you just got, I'm so stressed, I gotta go to the bathroom now. I gotta go to the bathroom now. It's just hard on your body. Ulcerative colitis, now this ulcer probably is different from this one because this is ulcers that occur in what organ? The colon. And it's just little pockets that start to develop there. In the genital urinary system, we can get diarrhea. So I'm so scared I gotta pee now. What's impotence?
You can't pee, or you can't poop.
You can't get an erection.
I can't use my stuff. When you're impotent, you're unable to perform sexually.
Oh, shit.
Yeah, that one's another one that catches most people's attention. If you're really, really stressed, it's really, really hard to do your job. I mean, this is where you really got to admire porn stars because they don't have this problem. I'm under stress, all the lights, everyone's watching, I can still do it. How many of you think you could? Knowing full well that your mother's going to get a copy of the tape. Yeah. I had a friend of mine who made that comment once. He said he was studying whether or not we should release everyone's just on the internet. You can go up and look up, your flame of the week, look up and see if she has sexually transmitted diseases. And he said, I would love to have something like that, except what if my mom was checking? He doesn't care if anyone except his mother. Because mothers will judge you. How did you get that? And they know it wasn't from a doorknob. Skin, stress can produce acne, eczema. Think of all the times I got a really hot date and there's a zit right here. Endocrine system can worsen diabetes mellitus. So type 1 diabetes, type 2 diabetes can worsen just because of a little bit of stress on the body. And from the central nervous system standpoint, it just is tiring, leads to depression. We talked about inability to sleep. You just can't get to bed. Once you finally get to bed, you have a hard time getting out. All this has major impacts on it. All right. It's always amazing to me. We deleted about 10 slides in this thing, and it took out an hour and a half. Anyway, actually it took out 2 hours because it was always running late. What worries do you have about this section? Because there's a lot of little details on here we could ask just about anything. Read your book. Your book went into a whole lot more detail than we did. It'll answer a lot of the questions if you're looking at stuff tonight.